Mastering Holter study interpretation is a high-yield skill for cardiology rotations and board exams. Because Holter monitors record thousands of heartbeats over 24 to 48 hours, the secret isn't just knowing the rhythms, but knowing how to filter the noise and correlate data. Here are the top 5 pitfalls and examining tricks for Holter interpretation. The most common mistake is misidentifying motion artifacts as ventricular tachycardia or ventricular fibrillation. Rhythmic movements like brushing teeth or jogging can create sharp, wide complexes that mimic VT. The secret trick is look for marching R waves. In an artifact, you can often see the underlying normal QRS complexes peeking through the noise at regular intervals. True VT will totally obscure the baseline rhythm. Here is an example, not from a Holter tracing but from a routine ECG, where tremor produced artifacts resembling ventricular tachycardia, and you can see the QRS complexes marching through. Narrow spikes are seen. For comparison, there is an ECG taken when the tremor was not there. You see a 2.5 second pause on the report and immediately think of pacemakers. Overdiagnosing sinus arrest or AV block in a sleeping patient. In young athletic or healthy individuals, high vagal tone during sleep can cause significant sinus bradycardia and even Morbitz 1 Wengi-Back AV block. If the patient was asymptomatic and asleep, you have to look at the time stamp. It's usually physiological, not pathological. That's why the criteria for pacemaker implantation always mention longer pauses during awake hours. Specifically, it is mentioned in most criteria. Holter software is notorious for mislabeling beats. Trusting the total PVC count or AFib burden on the cover page without checking the strips can be a pitfall. Always verify the templates. Templates of each complex interpreted by the machine will be shown, and if the software labels a wide beat as PVC, check if it actually a normal QRS with a bundle branch block pattern or a fusion beat. In exams, you may be given a summary that contradicts the provided strips to see if you will catch the error. But it may not be that simple. Holter software is notorious for mislabeling beats. Trusting the total PVC count or AFib burden on the cover page without checking the strips can be a pitfall. Always verify the templates. Templates of each complex interpreted by the machine will be shown, and if the software labels a wide beat as PVC, check if it actually a normal QRS with a bundle branch block pattern or a fusion beat. In exams, you may be given a summary that contradicts the provided strips to see if you will catch the error. Sometimes there could be ST segment changes when the person rolls over in a bed, but heart rate remains stable and there are no symptoms. Then there is a chance that it is false positive. True ischemia usually follows the rule of ones, that is 1 or more millimeter of ST segment depression lasting 1 or more minute, separated by at least 1 minute. That's also the definition. Correlating symptoms with what you see on the monitor is also very important. That's why we usually ask for a symptom diary. The person is asked to check the clock in the Holter monitor recorder and write symptoms according to the clock in the device itself, so that it can be correlated when the examination is interpreted, and the diary is usually submitted along with the Holter recorder so that it can be correlated. For example, if a person feels dizzy but ECG shows normal sinus rhythm, then the cause is not cardiac, something else. And atrial fibrillation can occur and the patient can still be fine, that is asymptomatic atrial fibrillation. And if we asked To say most significant finding, look for the moment patient press the even button. There are even markers on the tracing when the person presses the even marker button. That will be the best correlation, but many times it may not be there. Sometimes persons may forget to press the button, and sometimes it could be false positive also.